Hello, everybody. Welcome back. I hope you had a good break. And that was a fantastic presentation. I've had a few questions. A few people asked me, is that presentation recorded and will it be available to us to watch and share later? Absolutely. It takes us a few days. We'll do our best to get these on our website, on our YouTube channel for Monday. And we'll also send out the YouTube links to everybody. So our target will be to have that ready for Monday so you can share them and watch them again in case you missed anything. Now, I'd like to introduce our second presentation of the day. And this topic is PD memory, very important. Dr. Rodolfo Savica is with us. Dr. Rodolfo Savica is a professor of neurology and epidemiology and a practicing neurologist, movement disorder, and behavior specialist with the Mayo Clinic in Rochester. Dr. Savica has a particular interest in early onset Parkinson disease and is leading initiatives of the Mayo Clinic regarding the clinical practice and research on early onset PD. He is involved in patient education as well as in scientific advancements, and he is also the chair of the International Movement Disorder Society Task Force on Early Onset Parkinson Disease. And he is leading lab with the goal to improve the quality of life and find a cure for people living with Parkinson disease. Dr. Rodolfo Savica, thank you very much for joining us. I'll hand it over to you now.
Hello, good afternoon, good morning, everyone. Actually, good afternoon. I'm sorry, I'm in a different time zone, so I'm a bit confused. So good morning to everyone. I'm happy to be joining you guys. And let me make sure first that I want to just make sure if you can confirm you can see the slides, that would be great.
We can see everything. Thank you.
Lovely, thanks. So today we didn't discuss about Parkinson's and memory. I just amplified a little bit the title of this particular topic, which, as you may know, is a very important topic, given the fact that very many people with Parkinson's disease, for different reasons, may have memory problems. So we had to define what is memory problems. We had to define the implication of having Parkinson and having memory problems and so on. So let me just make sure that I can go on through my slides. This is the overview. We will look first at some general frequency on how common are these problems in the population and in Parkinson's disease, and what is the best way to manage and to deal with these complications. So overall, the prevalence of cognitive decline, so in people that have memory loss, in people that have Parkinson's disease, varies according to the studies. And you still see me, or I think I pressed something wrong. Okay, good. Okay, according to the studies, going from 9% to 84%. As you can imagine, that's a very broad definition. According to the different definition on what does it mean to have a memory problem, people may have different studies. Clearly, 9% is not very much. 84% is too much. I would say that using the most current criteria that are the clinical criteria that have been developed by the Movement Disorder Society, we can say that around 25, 30%, 40% at the most of patients that have Parkinson's disease may have some memory problem. But that's the important definition. What does it mean, some memory problems? Our study shows that about 42% had some cognitive impairment. But this includes everything from frank dementia, so difficulties with the activity of daily livings, not able to take care of yourself, forgetting names, forgetting events, not able to pay bills and so forth, to minimal problems, such as, oh, I forgot where I placed the keys a few times and I reported that to my physician. So when we talk about memory, we had to identify that there is a spectrum of disorders that goes from very minimal symptom to a very severe symptoms. And indeed, you can see here in this study that the median age of diagnosis of memory problems in Parkinson's disease was 80 years of age. But I would like to tell couple of things about this data. First, after the age of 75, we all the humans are accumulating plaques and tangles. That's normal. It's part of the aging. And in fact, the single most relevant predictor for cognitive decline in the population is age. So the older you are, the most likely it is that you may have severe memory problems. And as you can see here, the most people die within 4.9 years from the diagnosis. The current life expectancy in North America is not above 89 years old in this moment. So we have to understand that a component of memory decline, it is indeed part of our aging and can be concomitant. So this means that can occur at the same time with Parkinson's disease, especially as we get older. And those are some curves to show exactly what I told you. As the time goes on, the frequency of memory increases, and obviously, as we get older, 4, 5, 6, 20 years from the original diagnosis, people tend to die. But if you've been diagnosed at the age of 75, likely at 95, you will die, because it's what humans are gonna be. Are they gonna die 20 years after that? It's interesting because when we look in our population, this is Olmsted County, Minnesota, is where I reside, and where Mayo Clinic is indeed residing, right here in Olmsted County. Well, in Olmsted County, Minnesota, we had this ability to look at patients from the day they were born to the moment that they die. And we were able to differentiate group of people according not necessarily to their symptoms, but rather to the protein that is underlying the disease. I mean that for the most part, people that have Parkinson's disease, dementia, Alzheimer's disease, other form of disorders, they accumulate proteins. And Parkinson's disease is caused by this group of proteins that are called synucleinopathies. It's important to say that having a diagnosis of synucleinopathies, it's something that increases with age, and it's higher in men than in women, and you can see this very well. There is this huge discrepancy around 70, 75 years of age between men and women, where men are basically double as compared to women. But you can see that this particular group of disorder, the one that are associated with memory loss, the dementia Lewy bodies, the Parkinson's disease dementia, are indeed increasing, exactly what I was telling you before, after the age of 75, because this is when we start to get older. We, all of us, not just people with Parkinson's disease. You can see when we clean the curve combining these two conditions, DLB and PDD, you can see indeed that there's a huge spike after the age of 70. And that's something that we are expecting because, again, we are aging. One thing that is very important, and this is interesting, prevalence is the number of cases totally present in a population in a given time. The prevalence of Parkinson's disease, it is 2% after the age of 70. So 2% of population in general have Parkinson's disease after the age of 70. But our estimates are very concerning, because we see that we will observe a doubling and a tripling of cases of dementia and Parkinson in the United States by 2060. So we're expecting that people would have much more evidence of dementia in Parkinson's disease. And you can see the curves. The curves are exactly what I was showing you before. Still this big spike, but the moment that we look at dementia, this is quite concerning, because we are seeing that with time, due to the aging of the population, due to the fact that this condition will continue to be on the rise for many different reasons, we are expecting patients with Parkinson's disease to be much more than now, almost doubling than now, and people with dementia in Parkinson to clearly be much more present in the population. This opens a lot of information, opens an entire set of information on why this is the case, why this is happening. Is it environment? Is it genetics? Well, it's a little bit of everything, clearly. And, for example, there's this study showing that people that have this particular mutation called GBA, that's a mutation that is quite common in the East Coast of the US, in North Africa, and also in Israel. But people that have this particular mutation, they seem to have Parkinson's disease with a higher frequency of having cognitive decline. So clearly, we will witness in the future the opportunity to see much more cases that have indeed memory decline due to maybe better understanding of what's going on. But the understanding for me is meaningless if it doesn't come together with a treatment. And identifying genetic mutations such as this can lead to treat better the patient that had this condition. But the most fear complication and most fear things that my patient come to see me, and I guess you all as well have, is that, oh my God, I have Lewy bodies. I have Lewy body disease. I heard about Robin Williams. I heard about this other patient, these other cases. I have all this concern that I have Lewy body disease. Well, unfortunately, Lewy body disease are present in Parkinson's disease. So even in patients with regular Parkinson's disease, without any dementia, Lewy bodies are present and are part of the disorder. If I cut the brain of people with Lewy body with Parkinson's disease, I will see these pathological features, which is the Lewy bodies. In some patients, however, there are some differences. One important aspect to understand the memory in people with Parkinson's disease is to know about this famous hypothesis. That's so-called the Braak hypothesis. And this is telling that Parkinson's disease does not start in the brain, starts in other part of the nervous system, specifically initially in the nose, in the gut, and then with time it can ascend, can go up to the brain, affecting the motor centers, and then later on affect the entire cortex, causing memory loss. This is a very simplistic view of what happens, but it is a valid model on how the disease progresses, because that's what we know. We know that if on the right you see the presence, the onset of motor symptoms, so tremor, rigidity, stiffness, there are a number of other symptoms that can occur before tremor, stiffness, rigidity, falls occur, including anosmia, REM behavioral disorder, constipation, anxiety, and you can see there's a group of patients that right away tells you, you know, I have memory problems, but I did the testing at my doctor, and he says or she says that I'm doing fine. But yet, I don't feel that my brain works. I am in a brain fog. And that's something that can occur before the motor onset. Why I'm telling you that? Let's keep this one for now. Because if you go back, I'm sorry, to this one, you can see that together with memory loss, depression, anxiety are hand in hand. When we talk about memory loss in Parkinson's disease, we had to ask ourselves, what are we asking about? Are we really asking about a pure forgetfulness of some names or something more than that? Or it is part of something different, affecting also the mood, being more short, being more stressed, being more fast in responding to external agent and so forth. Hence, it's very important, let me go this first, to also discuss about the fact that depression may be indeed the first symptom of memory loss. About 40 to 50% of all the cases with Parkinson's disease have depression. And depression seems to be occurring before Parkinson's disease starts. And can be hand in hand, walking together at the same time with memory loss. And your physician can tell you, yourself know, sometimes it's very difficult to know what is what. Is it depression? Is it anxiety? Is it something else? And in fact, when we talk about dopamine, everybody talks about this nuclei here that I point with my arrow. This is where the dopamine is thought to be. And you can see with the DAT scan, with everything else. But dopamine is everywhere in the cortex. Dopamine is what led me to talk to you today. Dopamine is what helped you this morning to wake up. You need dopamine to live. You need dopamine to guide your life. And that's crucial to know, because it's something that if you do not do it properly, if you don't have enough dopamine, you have a lot of symptoms that are beyond movements, beyond tremor, but they are indeed affecting also the mood, affecting the anxiety, affecting memory. And in fact, I talk about anxiety. Anxiety is something that can come as well hand in hand with the memory loss. And you may also feel that if you're anxious, your memory is worse. If you're anxious, your symptoms of Parkinson are worse. And that's very much typical, because the symptoms of Parkinson are the weak spot that the brain is using to release stressors. And you can see on how this anxiety can precede the onset of Parkinson for a long time, even 20 years. And then when we talk about memory, we have to talk about another problem people are having. One of the most worrisome aspects of memory loss is the presence of hallucinations. If you have problems with hallucinations, people are worried. Remember though, hallucinations, let's define hallucinations. Hallucinations are very well-formed, shaped figures when there is an interaction between the patient and the hallucinations. And they're occurring during the day. They do not occur at night. What happens at night is something different. That is not hallucinations, but is rather a sleep disorder. It is interesting because when we see people that have hallucinations in Parkinson's disease or in DLB, usually people that have hallucinations, they respond, and again, guys, I'm talking about usually, usually they respond better to some of the medication that we can give, especially to one of the medication that we give to try to boost up memory. And memory can also improve with that. But many of you may have this idea that you may have some visual symptoms that are difficult to identify. And sometimes you may see shadows in the corner of your eyes or things that pass and you don't know exactly what it is. Those are not hallucinations. Those are what we call visual misperception, that despite at times they can go into full-blown hallucinations, most of the time they don't. And they're really a phenomenon that does not need to be treated, usually, unless it's becoming very intrusive. But usually does not need to be treated. One thing that is important, that whenever we talk about memory and hallucinations and anxiety and stressor, there's always this risk of what we call psychosis. Psychosis is a status when people are confused, agitated, they're seeing things that are not in the room, they're clearly having memory problems that are quite severe, and sometimes can be in the late phase of the memory decline. We know that patients with psychosis may have a lot of problems, may are the one that have the increased risk of dying, unfortunately. And unfortunately, I have to say, men are much more prone, much more likely to have this condition compared to women. Remember, we have to also make sure that whenever we are talking about psychosis, there's not a secondary problem, such as, for example, a UTI, a pneumonia, or things that can make our memory and our symptoms of psychosis worse. And here you can see very clearly, this is a survival curve showing how men in blue and women in red are very different. They never touch each other, showing how men seem to be dying way more often than women in comparison, given the fact that all of this psychosis seem to be more common in men compared to women. But it doesn't mean that everyone would have a psychosis. This is something that happens later in life, as I mentioned to you, and usually happens in some circumstances, that some of them are yet to be defined. But for sure, people with psychosis and memory loss together, when psychosis is together with memory loss, there is an increased risk of having hospitalization. And you can see, we know that the medication used to treat psychosis, they don't seem to be doing very much in helping the psychosis per se, unfortunately. But let's say something typical. You have Parkinson's disease and you have memory loss. Or even without it, you just started, but let's say you have memory loss. There, your physician is going to see you and say, you know what, let's order some tests on you. The first test, that many of you will order, it is an MRI of the brain. But the MRI of the brain does not tell very much. On the left, you can see a normal MRI of the brain. And in the square, red square, there are these structures called hippocampi. Hippocampi are the short-term memory center of the brain. And you can see somebody normal, somebody with the Alzheimer's disease, where you can see this blackness here. This is something that happens when these areas are shrinking down and they tend to vanish. Then you have symptoms of memory loss. But look at this. This is somebody with dementia with Lewy bodies. Parkinson's is dementia. Basically, this is identical to the normal one. What does it mean? Means that the short-term memory loss that you see in Parkinson's disease, in dementia Lewy bodies, it is very much different than what you see in Alzheimer's disease. Don't get me wrong. People can have both. People can have Parkinson and Alzheimer's, clearly. But the memory loss that comes from Parkinson's disease, from dementia Lewy bodies, it is very different. And when we do something funnier, something more interesting, like, for example, imaging that are more functional, such as PET scan, this is a beautiful example of a normal PET scan. I would like everyone to look at the bottom screen. In this particular screen, everything that is dark blue, green, dark blue, it's normal, okay, on the bottom. And that's a test that can be ordered and can tell you if you are indeed developing dementia. This is somebody with Alzheimer's disease, and you can see yourself on how some areas are really red or really green. This means that these areas are not working very well. And those are the areas that would always not work well in Alzheimer's disease. But if I compare with what we see in Parkinson's disease / dementia Lewy bodies, it's completely different. I will go back and forth between the two scans. Alzheimer's disease, dementia Lewy bodies. Alzheimer's disease, dementia Lewy bodies. If you look at this area here that I point my arrow, you can see that it's very different. In dementia Lewy bodies, in Parkinson's disease, the posterior part of the brain, what we call the occipital cortex, is much more involved. And the occipital cortex is fundamental for what? For visual symptoms. Therefore, the hallucinations are having a perfect explanation. Whereas in Alzheimer's disease is different. The pattern, the way it looks is different, telling us that despite both of these conditions may have memory loss, the memory loss is completely different. And let's say you have finally seen your physician after some time, and you say, you know, I have Parkinson's disease and I have memory loss. What I should do? The first thing we have to be doing, we have to understand what is the nature of the memory loss. Therefore, we have to order the test that I mentioned you before, MRI, PET scan, maybe doing a memory test. And then we have to understand at that point, do you have or you do not have additional problems, such as anxiety, depression, sleep problems, everything that can absolutely contribute to the memory loss. Let's assume that all is fine there and we have done all the tests. At the time, the first thing to do is that we have to ask, how much are you bothered by that? Are you really bothered by these symptoms? Because if you are not bothered and you're more feeling about that we are dealing with something more subjective, so most of feeling or a perception and memory is not good, then education and counseling, it will be enough. Otherwise, there's a bunch of medication that can be used that can be of help. For example, anticholinesterase inhibitor, something called donepezil, that can be very good to be taken in the morning time, not at night, to try to have a good effect on the medication, on memory. But the most important thing, other than stimulants and neuroleptics, is this, L-DOPA. People with memory decline and Parkinson, the first thing we have to be doing, we have to make sure that they are taking correctly the right amount of L-DOPA, of dopamine. Without that, we have a problem. If our treatment with levodopa is not optimized, people may have, not only people may be slowing moving, but people may be slowing in thinking. And that is a very relevant aspect that is much overlooked by many. But we need to be considering that L-DOPA is not only helpful for movements, but is incredibly helpful for memory. And in fact, this is a repetition. In fact, despite as being used for many years, the use of donepezil, memantine, galantamine, rivastigmine, medications that you may be familiar with, the first thing to do is always optimize the treatment with carbidopa levodopa. And to further support what I was telling you regarding the difference that we have between the memory loss in Parkinson's versus the other form of Parkinson, form of memory loss such as dementia, I would like to mention, look, those are the results of the memory testing. You can see here we talk about global in red, in black, memory, language, attention, and planning and the posterior part, the visual spatial. The first on top is Alzheimer's disease. So the global result is the same between the two. But look at the different colors. In Alzheimer's disease, the red portion, which is the memory per se, is well below the yellow curve, which tells me that this is the norm, so it's below the norm. So people have short-term memory problems. In dementia Lewy bodies, in Parkinson's disease, is all different. Is all attention, executive, and the visual spatial, the posterior part of the brain. So the difficult part in Parkinson, not only something is different, has to do with planning, multitasking, execution of very complex planning. Those are the things that usually are affecting people with Parkinson's disease the most in terms of memory. And look at that. That's what we do see in patients that have dementia Lewy bodies or Parkinson's disease. We are doing this test, which is doing a cube, draw the clock, draw this figure, and you can see that this is very complex doing these tasks. Why? Because the occipital cortex, the part of the brain that is responsible to tell us where we are, to acquire information and to give the meaning to the visual information, is not working very well. Therefore, you may look way worse on paper testing than what people really are. An important aspect that I want to mention, and to me is crucial, they do it every single time, is that when we are dealing with visual hallucinations as part of the memory loss, we need to be obviously try to optimize the treatment. But you know, hallucinations, depression, anxiety, agitation, you can try different meds. The most important thing is that we don't want you to use alloperidol, Haldol. Haldol is a medication that belongs to a class called D2 blockers. These particular medications are the so-called antipsychotics and are the so-called old antipsychotics. And those are not really good. Those can worsen the symptoms, even markedly worsen the symptoms. There's a new medication that is being available in North America, mostly in the US. It's called Prevalence, Nuplazid, that seem to be working in psychosis with Parkinson's disease. There was in the past the concern that it was increasing mortality, but that it doesn't seem to be the case. One thing I want to mention, likewise here, depression can be form of cognitive decline. The first thing we have to be doing, we have to replenish dopamine to work with depression and to work with memory. L-Dopa is the number one, Cinemet. Then there's a number of other medications called dopamine agonists. We have to talk about it. And then there's other medication. Clearly, antidepressant can be used. Cognitive behavioral therapy can be used according to what you need. But I need to talk about this class called dopamine agonists. You may be familiar with that. Those are the roticotin. This is Mirapex, Pramipexole. You all know about this medication. Well, this medication can cause a lot of side effects, can cause hallucinations, delusions, can cause sudden somnolence. So people were driving and all of a sudden they fall asleep. They behaviors in 8 hours time doing one hobby, and maybe the hobby would be reading, so not bad. But if you spend 12 hours reading, I have a problem because it's becoming intrusive. Can cause orthostatic hypotension and edema. But I didn't put it here on purpose because I want to tell you with my own voice. But this medication can worsen memory. So whenever somebody has memory loss in Parkinson's disease, whenever somebody has memory loss and depression and hallucinations in Parkinson's disease, the first thing to do is that are we taking medication that are maybe causing this problem? Second, do we have infection or something that can affect this particular situation? But since these medications are quite used, and since the side effects are quite common, I want you to be very well aware of that, because the change can be marginal, can be easily changed just by changing the medication again. And in fact, it's been shown that people that are having impulse control disorder, which is what we call these complications with dopamine agonists, it is increased the risk of having this condition in patients with depression. So it's a common thing, and we need to be knowing about that. Another crucial aspect that I want to mention for memory, practical things that we can do. We all worry about memories, but if you don't sleep well, your memory will never be good. And this is not because you have Parkinson. This happened to all of us. If, as today, myself, I'm sleep deprived because I'm flying all over the nation and I'm in a different jet lag and I don't sleep well, and tomorrow I have a flight at 3 a.m. and so forth, for sure I would not think straight and I would not feeling in a fog myself. So make sure that before you start any other things, you have an adequate sleep pattern. And the most common symptom of lack of sleep, or problem with sleep, is lack of dopamine. Therefore, if you have problems to falling to sleep, can't get to sleep, you can use a full dose of your immediate release carbidopa. Or sometimes if you have problems in the middle of the night, waking up, using carbidopa extended release can be a good idea. Or maybe taking an extra booster. But why you do that? You do that to sleep better and, more importantly, to improve your memory. Because if you have untreated sleep apnea, if you don't sleep well at night, your memory would be impacted. And it can take some time, I'm talking sometimes months to get better with that. That's a very important aspect that we need to be considering. It can take months for that, okay? Now, that's a great question. I will answer later. It's true. It can happen as well. Yeah. We will answer later question because a very important question comes in the chat. I love that. Another possibility is this, is REM, sleep behavior disorder, tendency to live out your dreams. Kick, punch, yell, move, trash, punch your partner, or worse, punch, fall down, break a bone, have some bad consequences. And this is another example of sleep fragmentation that can affect the memory. In this situation, the best thing to do is using melatonin up to 12 milligrams, or if it doesn't work, we recommend using clonazepam. But we have to be careful because we don't want you to be overly sedated. Then you go to the restroom, you fall. And it's not good. And it's not good. Because if you're not feeling well, you may fall, and fall, it is our number one enemy. More than anything else is falling. But falling can be a consequence of medication sometimes, or can be a consequence of lack of dopamine. I would like to stop here. I went a bit faster because I want to have more questions than anything else. I would like to make sure that we will talk about the consequences of memory, but also remember, in Parkinson's disease, memory can be part of that, but memory can be a symptom of something completely different that we can tackle, and treat somehow. I would like to thank you, and thanks again for being here today. I don't know in Alberta, Rochester is not yet It's not yet snowed, but soon to be. But currently, I am just for today in Los Angeles when the weather is quite good. So
Thank you so much, Dr. Savica. I'm Charlene. I'm one of the client services coordinators here in Edmonton. What a fantastic amount of information. And I do have a few questions.
yes, yes. There's a
All
couple
right.
that are in the chat that I saw, and they're very important, actually.
Yeah, so the first one was related to melatonin, and I think you answered that question, or was there anything that you wanted to expand?
There are a few things. So melatonin is usually it's considered a benign medication, but no medications are benign. Nothing is benign. They all cause problems. So melatonin can be good to be taken before going to bed. I recommend starting with 2-3 milligrams, then increase to 6, 9, up to 12 if tolerated. But I would like to say the melatonin can cause increased or vivid dreams, can make people having a little bit more tendency to have more vivid dreams, not necessarily leaving out the dreams and punching, but really the content of the dream can be a little bit more colorful, more vivid. So I want to make sure that people know about that. But there's no concern about increasing up to 12. So there's something that can be done 20, 30 minutes before bed. That's important.
Another question that we have is there anything that a person can do to slow memory impairment?
Excellent question. That's questions. So unfortunately, even in the behavioral world, even in dementia world, even in Alzheimer's disease, we don't have a way to delay the progression of diseases or memory decline. We know, however, there are a few things that are really relevant that help reducing the risk of further decline when present. Number one, cardiovascular health. So let's make sure that cholesterol, that blood pressure, that there's not a heart attack. Make sure that from a cardiovascular standpoint, everything is under control, because we know that the people that are doing the worst are the ones that have also uncontrolled hypertension, uncontrolled hypercholesterolemia, uncontrolled whatever. Why? Because it causes an increased risk of vascular damage that can worsen the memory when present, memory loss when present. Number one. Number two, and is together, exercise, working out. Working out means I always recommend my patient 30 minutes, or at least 30 minutes, 5 times per week. Something that makes people to be a little bit perspiring, sweating. So make sure that, somebody mute, because I have a return. So the idea is to try to walk. Strolling in the park is not good.
Okay, that's something.
Sorry, there's somebody getting in. Okay, strolling in the park is not good. Walking briskly is okay. It's okay. Running is better, or maybe biking is better, or going to the pool, the swimming pool is better. I remember a patient told me, you told me to perspire, to sweat, but I go to the swimming pool so I don't sweat. Say, well, it's not a matter of perspiring. It's a matter of having the heart rate increase. That's what it is. Okay. The third thing I would recommend to delay the progression, to try to delay the progression in general, is, and this is an important one, sociality and pleasure. So being social, having some pleasure in life. That doesn't need to be exotic. It can be simply walking the dog in the park every day and having good time doing that. And the last one, that should be the first one, is make sure that the medication you're taking are proper and are adjusted properly. Because as we know, we have to adjust medication as we go many times. So having a rapport, a relationship with your physician or your PA or whoever is taking care of your medications that is good and constant, allows you to make changes, is very important. But I don't have a silver bullet. I wish I had one, but I don't.
There is a question asking about cramping. Is there a specific medication that helps cramping associated specifically with Parkinson's at night? Is the lack of sleep making the brain fog worse?
Absolutely so. The lack of sleep makes everything worse. Makes memory worse, made the so-called brain fog, as Danton says, worse, absolutely. Cramping usually has to do with lack of dopamine. So if you're taking medication during the day and you don't take it at night or don't take enough at night, then basically cramping is nothing but a milder form of dystonia that occurs, cause the whatever muscle, usually the legs, to be clenching and waking you up. So usually with MI patients, obviously there's magnesium, there's anything else that we can do, that's all good. But I say, let's optimize dopamine. Let's make sure that you're taking the right amount at the right time. And sometimes if you're awakened by cramp, take an extra dose and go back to sleep. And the way to take an extra dose is to take it with carbonation. Remember, carbonation, carbonated water, carbonated soda is a way to speed up the absorption of the medication quite a lot, of really like few minutes, very, very fast, actually, I would say. So for a nighttime dosing, having the medication next to having the medication next to a piece of a cup of water that is carbonated would be a good idea. There's I'm sorry to tell you, there's one that is very important. Caroline Brown writes, can you have sleep fragmentation with WOPA? Yes, you can. Yes, because it's not to do with in the case, the sleep fragmentation can be caused by, for example, dream enactment behavior, or sometimes periodically movements at night, or sometimes a phenomenon of augmentation that sometimes happens to people that are restless leg syndrome after they're exposed to a long time with levodopa. Remember, dopamine is not the sole problem in Parkinson's disease. So DOPA can help, but then other things need to be done to improve the fragmentation of the sleep for sure.
There is another question here asking about mood and cognition. Can you comment on that?
Sure, absolutely. What is exactly the question, if you can ask you?
The question is, would depression worsen cognitive ability?
Absolutely. If you, as I was mentioning, depression, mood disorder, any even mild mood disorder, even situational anxiety together can worsen for sure our memory. And this is not only valid in Parkinson's disease, but it is valid for depression overall, per se, anxiety per se. In Parkinson's disease, there's another problem that we have to consider, especially if you're taking medication. Sometimes you may have a fantastic control over your motor symptoms, tremor, rigidity, but yet the medication is wearing off, and the wearing off phenomena are anxiety, are depression, are symptoms that are indeed mood. So clearly mood has to do with lack of dopamine, but you have to treat the mood disorder that can be a reaction to the disease per se, because if the depression is untreated, for sure, people have memory impairment, regardless of Parkinson's disease, but especially in Parkinson's disease.
Another question here. It says sleep apnea can help for sleep. I'm wondering if they meant CPAP.
Yeah, CPAP, for sure. So sleep apnea is not good. Nobody should have sleep apnea, okay? Sleep apnea means that the oxygen level is dropping too much at night. And if untreated, that can cause other problems, including memory loss. And as we know, as we get older, many people with Parkinson have sleep apnea. But CPAP for sure can help treating the CPAP, but other devices. There's many devices. CPAP is just one of them. That needs to be treated for sure, because that can cause a lot of problems and needs to be treated properly, because that's another risk factor that can worsen memory.
There is a question here. Could you comment on the risk of cognitive issues for someone with GBA risk factor? Is there a higher incidence of GBL or DLB, pardon me?
No. So no. There's not an incidence on DLB, that's for sure. We know that some allele, so whenever there's a mutation, there are different types of mutation that we see. Some people that have GBA mutation, some specific alleles, so some specific variant of the G mutation, seem to be slightly more, can cause a bit more memory problems compared to the one that don't have it. But also we have to say that depending on the different allele, a different mutation that we see, some people that have GBA mutations are doing really well. They don't have any problems. Actually, seem to be almost benign, more benign than others. So it's not necessarily the GBA mutation in general, but what kind of GBA mutation? And is it only the GBA mutation, or but there's something else on top that is playing a role, like another mutation that can be combined with the GBA? Those are questions that need to be asked and and tackled every single time.
Passengers passed through the long acre station. One of those shrewd businessmen was
Any other questions?
Sorry, one more question.
Sure.
I notice I'm having difficulty understanding complex ideas and conversations. Is this common, and what can I do to possibly improve this?
That's exactly what I was mentioning before, knowing multiple step commands, multiple action, multitasking, being part of a conversation when there's many people talking and you have to listen to one and then the other again. Those are the difficult part, the difficult part. Those are the one that people with Parkinson struggle more than others. The best way to do it is to, for sure, talking to your primary physician and trying to find ways to optimize the treatment that you're taking, reducing things that can contribute to make you worse, and boost up your memory. And as I mentioned, you can boost up your memory in different ways. Sometimes you're successful, sometimes you're not successful, I would say.
I like this question. Can caffeine be beneficial?
For what? For it's
For
good.
your memory?
No, I'm just kidding. I'm just kidding, clearly, just kidding. Caffeine is beneficial in a sense. No, it's not. It doesn't seem to. Caffeine is a little stimulant, and caffeine has always been studied through the years to see whether or not it was a possible medication for Parkinson. The results have been controversial, means that it's not clear whether it's good or bad. For sure doesn't seem to be bad. For sure doesn't seem to be bad. Whether it's good is debatable, but I would say for sure, one thing I want to mention that seems to be silly, but caffeine is not bad for you. It's been shown that it's not bad for you. Maybe it would not help memory, but for sure it's not causing any problems. So would I have my patient drinking caffeine? If they want to, if they like it. I would say, being Italian, I would say a good espresso is a good thing to do. And that would be always good. That would be always, but again, is a little bit, it's not necessarily something that I would jump right away on that.
There are just a couple other questions. One of them asks about Zopiclone for sleep. Is that something that's recommended?
It's a good medication. It's a medication. So it's not a good or bad medication. Depends on the profile of the patient. Depends on how the patient ever responded to something different. Person is not my first choice just because I have others that I usually do, but depending on how the patient present. But it's not necessarily a bad choice, depending, again, on what are the symptoms of the patients and what we have to be doing with that.
Yes, you can, I guess, yeah.
Okay. No.
Okay, all right, thank you. So we'll see.
Any other questions?
There's one that's asked about nicotine patch, if it's helpful to reduce Parkinson's symptoms, but I'm not sure that's something that we'll address in this one.
No,
I
but
just,
the answer is
there
no.
are a few questions wondering, one of them's asking about modafinil. So different things that potentially are specific to specific people, which we did say at the very beginning that we wouldn't be addressing individual questions about those sorts of things. So I just want to say, I think we're almost at the time where Dr. Savica needs to
Yeah, I have
move on
another
to
lecture,
something
of course.
else. Yes.
I have
So I
another
just want to
lecture
say,
somewhere else. I'm sorry.
yeah, thank you so much. It's been a pleasure listening to you present to us.
Absolutely.
We do have a few other questions that I will reach out to you if you have time, and we
Please.
can answer them that
Please.
way. But again, from Parkinson Association, I just want to say thank you so much for sharing your expertise with all of us, and we'll hope to connect with you again. Thanks so much.
For sure. Thanks for inviting me, and I wish everyone a beautiful day.